Colleagues, and welcome to. Firstly, my name is Vigen Naika, and I'm part of KISA KZN. Today we have a webinar from Mindray, and it is titled Emerging Technologies in Modern Anesthesia Practice. So this session will explore the latest technologies and clinical solutions that support safer airway management, optimized anesthesia delivery, efficient gas monitoring, and greener operating rooms. Our presenters today, we have Tabani Buthelezi and we have Luc van Wyk. So just a little bit about Tabani. He's a clinical application specialist at Mindray South Africa. He's got vast experience in the field of clinical applications and has been involved in clinical education. His experience includes advanced ventilation education in the industry. He's gained experience in various disciplines, including the operating rooms, intensive care units, and patient monitoring. Tabani's worked in various countries with different healthcare professionals. He worked in countries like Botswana, Namibia, Angola, Malawi, and Mauritius. And he's working in South Africa at the moment and across all provinces. He's gained a lot of experience from his extensive training from different European countries. He's also trained in China with Mindray on patient monitoring and life support. And Tabani is using his clinical expertise and clinical application knowledge to support the different Mindray distributors in South Africa. Tabani will be followed by Luc van Wyk. Luc is a qualified biomedical engineer and an AI enthusiast. Luc's got more than a decade of professional experience in biomedical devices, and he's acquired extensive knowledge ranging from radiology and imaging through laboratory to ICU, operating rooms, and life support. He's had the opportunity to collaborate with multiple medical professionals from South Africa and abroad, including Angola, Zambia, Lesotho, Turkey, Egypt, Mauritius, China, and Namibia. Luc is currently providing expert support as the Mindray patient monitor and life support and IT service engineer for the Southern African region. He specializes in technical training and advanced technical support with customer and distributor management. So without further ado, and thank you all for your patience, I'm going to hand over to Tabani. Thank you very much. Enjoy the presentation.
Good day, everybody. Good afternoon. I'm going to be presenting the hybrid anesthesia technique on the anesthesia system. So in my presentation, I shared a little bit of some history of the anesthesia before we are where we are right now at the moment. So as it starts then, like as I'm saying then, like the history, it takes it like the history of anesthesia. It's just like it's been like it started a long time ago during even the times of Shakespeare. So as it shows here, the observation from somebody explain why attempt to alleviate the pain of disease, injury, or simple surgical procedure by producing unconsciousness are almost as old as civilization. Although the techniques were crude, most involve ingestion of ethanol and herbal mixtures, but knockout blows to the head by and bilateral carotid artery compression. So where the carotid, the carotid artery on the other side is being pressed or being oppressed, and then so that the patient can be able, or the human being or the patient can be able to knock off. And then it's also described they were harmless. These methods were impossible to quantify, and the best that can be said of many is that they were harmless and harmless ineffective. But that is obviously not the case with the head trauma, where they knock out the human being or use the or obstructing the blood flow on the carotid, where they're obstructing the blood flow to the brain. Hypnotism also was introduced in other areas. So most of the herbal mixtures also were devised most in Southern Europe and in the Orient, where plants with active alkaloids, opium, are indigenous, but one called dwale appears in medieval English text. Although several drugs used in modern anesthesia have their origin in substance found in plants, those are only concoction are irrelevant. to the development of ineffective drug-induced anesthesia. So mostly of those drugs, like I think we all know that the drugs are mostly developed or developed from the plants. So even the one that we are using at the moment. So, but then they're coming from a long way as it comes like on these times, like in the Oriented or the Orient or Southern Europe, where they were using the same plants to be able to just like induce like the unconsciousness to the patient before they can be able to do like whatever procedure that they wanted to do. So there were different discoveries. So up until it came to the point where the discovery and the study of the gases. So the runabouts, Joseph Black, in the 1754, so discovered there like the oxygen and nitrous oxide. So as with other scientific development, the therapeutic possibility was explored and pneumatic medicine was born. However, Thomas Beddoes, once black student, was different, establishing a pneumatic institute near Bristol in 1798. So if you look there, like different researches, like at different times, it worked on this up until they were just now starting to move, because at one stage it was like stagnant, it was not moving anywhere. The milestones were at one stage like very, very stagnant. So as much a much less well-known figure interested in the inhalation of gases is Henry Hill Hickman. He induced the inhalation of carbon dioxide, performing operations painlessly on many animals under its influence. So if you look here, they were also the first specialists. A very few individuals developed special interest, as I've mentioned above. So up until it comes to the point where then it's around about 1853, and then the chloroform was also introduced. The same chloroform was introduced and was given to Queen Victoria for the birth of Prince Leopold and Prince Beatrice in 1857. So there's like a lot of changes now, as I'm saying. Then all these metamorphoses like was starting to just start to fly them right now. Then the local anesthesia was introduced. The muscle relaxation also just like followed like after that. So then from around about 1853 to up to now, so everything was getting more and more faster. And then induced hypotension was introduced in 1948. Subspecialty development development as well. As modern medicine advanced, it became apparent that lives could be saved if a patient cardiovascular or respiratory failure were to be managed while primary treatment dealt with the underlying diseases. So you can be able to see from the carotid blockage, then they would be able to see now that cardiovascular and respiratory failure were to be managed while primary treatment dealt with, which means then like if then you compare the two, that's like it's a lot of opposites. So if you look here, then like this is that's where like we all like where we are. So right now there is a perioperative, intraoperative management. So meaning that now all these, even whatever that was happening before, so it's being now tied together and use the same terms now. So like during perioperative and intraoperative, now there is an inhalation and intravenous. There is intubation and tubeless. So meaning that like all these things, they can be able to work together now. So I cannot be able to, I won't be able to read everything that is there, but it's just shown then like where then like perioperatively preparation of the management of the blood pressure, then intraoperatively management of the blood pressure, and then the bleeding. And then inhalation, and then on the inhalation side, like that is when anesthesia can be able to work on that. Intravenously, the infusion pumps can be able to work onto that. And then intubation, where the tube is introduced, or they just use the high flow, or in these days, also the jet ventilation is being used. So there is like, if you can be able to see, the changes are becoming faster, like and quicker, like than the times when everything was just changing then. So the anesthesia is becoming more versatile due to evolution of anesthesia scope, more obesity and elder patients, non-operational room anesthesia, anesthesia workforce deficient, device connectivity and data availability, COVID-19 challenge, then afterwards. And that's where we are right now, just after that. So these are different stages that comes to that. And as you can be able to see, anesthesia becoming more versatile depending on the situation, and it becomes much more broader and it's comprehensive. Unlike in the olden days, it was just like concentrating on one factor. So now what is more also important is that the safety measures that are being, as much as is being developed, but what about the safety measures that is being done? So as I was saying, that anesthesia is becoming more versatile. The customer asks for anesthesia safety at the higher level, considering the anesthesia modes, type of surgeries, and patient individuals. So these are different like factors that now needs to take part on that when it comes to the anesthesia. So when it comes to the modes of anesthesia, we've got combined intravenous inhalation anesthesia, so intubation anesthesia, intravenous anesthesia or sedation, and or tubeless anesthesia. So also all depends on what kind of surgery it's like is involved. Is it neuro, airway, ENT, cardiothoracic, hepatobiliary, digestive, or urinary? And it also, the factors that need to be considered. What kind of a patient that is being involved in that? Is it an adult patient? Is it a child, a neonate? Is it an elder, obese patient? Or is it during maternal times? So then with that, then that is where then like decision has been like taken. Like in the case of this, in the general OR, that's how now it's like getting like to this point. And the induction area, that is where most of the precautions are being taken. There is also interventional radiology, there is electrophysiology, transesophageal echocardiography, endoscopy, radiology, and interventional pulmonary suits, just inside the anesthesia on its own. So there is a lot of subspecialties that are involved there, depending on what kind. But what is more important is the precautionary measures that are being taken. So when in an emergency, but the environment is so cluttered, so there was a time that like you find that the theater's looking like this, where we've got all these things. So you've got ultrasound here, we've got ECMO, we've got everything that is like in one. So we find that like it makes it very difficult even for the healthcare professionals to be able to work around. So as then the time goes on, all things are changing. So as you can be able to see here, ICU level ventilation anesthesia. So if you look here, you can be able to see that everything is in order, that is safe, everything is efficient and cost effective as well. If you look on the sides, you can be able to have the anesthesia machine, infusion pump, all these things being integrated. And then you've got even ultrasound being integrated to all these things. And you can be able to see there is an order. And like if you compare with this the previous one, you would be able to see that there is a lot of machines, which also doesn't give like if there is such disorder, it makes it very, very difficult for even a healthcare professional to be able to work around. But in this situation, you can be able to see everybody would like to see himself in the situation like this. So where you can be able to have the screens and all the screens being shared, while all this interventional is being done, or different kinds of subspecialties being involved. So as it shows then, mostly now in OR, you may find that you've got ICU level of the ventilation part, where there is a comprehensive ventilation modes to meet different patients' demands throughout the perioperative period. So there is another one, like the one of the modes that you talk about, it's adaptive minute ventilation mode, which is most of people they will tell that's volume targeted ventilation. So in a broad term, so where it allows is switch over between controlled and spontaneous ventilation without extra adjustment. So meaning that like if you've got a patient that's being prepared perioperatively, intraoperatively, and post using only one mode. So with that in mind, that is where the developments are. So as you can be able to see, like if then like you're using the certain mode, or you can be able to use this like intubation, or you can talk about non-intubation side. So where you can be able to use the high flow nasal cannula for safer induction. So meaning that like you just give tubeless surgery like before everything has been done, and then you can be able to have the the flow between 2 to 100 liters per minute and FiO2 as adjustable as possible. So lately, we've got also the jet ventilation now, where for shared airway surgery, in emergency like airway, etc., where you can have the double jet channel with the airway pressure and CO2 monitoring. So which makes it easy if maybe then you've got a certain procedures like ENT, or you've got like emergency airway, or somebody cannot be able to ventilate, you can be able to use the jet ventilation. So these are the different ways now that can be able to be used. So that's how improvement, that's how much of the improvement that's been done. So as I was saying then, when it comes to the high flow, so normally when it comes to the high flow nasal cannula, it's prolonged the safe apnea time for 30 minutes. So before you can be, if maybe then the healthcare professional or the doctor is struggling to be able to intubate, can be able to use the high flow in the meantime for around about 30 minutes, like you're saving the patient from apnea. Then the different modes, as I mentioned before, there are different modes that you can be able to to use. And you've got even lung recruitment maneuvers with also the low tidal volumes. So meaning that like from theater, the patient is being saved or being protected to any harm to like to the lungs. Therefore, like it also prevent the complication post-operatively. So if you can be able to see, these are the some techniques that like I just showed, inspirator and expirator hold, where you can be able to recruit the lungs when maybe the lungs has been de-recruited during the session. So this is what like where you can be able to even monitor the driving pressure and mechanical power. This is happening in theaters. I was saying that you take the whole ICU, you put it in theater, and you can be able to ventilate properly and be able to get the better results. So this is like in the olden days, or this is maybe like some others, this is how the theater looks. You've got the pub, you've got ECMO, you've got like all these things cluttered all over. Even if you're trying to walk around, you find the healthcare professional, they even tripped all over these wires. So what we talk about technology now, if you see on the right, that is how the technology is. That is where it is now. So you don't need to trip all over because you can be able to integrate the whole solutions into one and have only one screen. So if you can be able to see, then like you can see shame like the doctor there trying even bending down, trying to increase the infusion instead of using the newer ways of technology. So if you can be able to see, you can be able to have almost everything being centralized. Have the one solution for everything. This is what is happening right now. That like the technology has improved in such a way that you can even use the Bluetooth. That is what is happening in anesthesia these days. So this is what it shows here, that like even that information can be transferred to central station. That information can be transferred to the to the information system. So this is where this is how technology has moved. So the take-home message onto this one, that the anesthesia has undergone extensive metamorphosis, which is it is essential for the healthcare and clinical professionals to keep updated with the technological advances for safe patient care. The larval and pupal stages were gradual and slower, as in the real narrative of metamorphosis. The stages at the moment are coming quicker and demanding to the clinical and biomedical professionals to be updated all the time. The solution is more integration and streamlining with the digitalization of the healthcare. I thank you.
Thank you, Tabani. Good afternoon, everyone. Thank you for attending our webinar. I am Luke van Beek, the biomedical engineer for Mindray South Africa. So I would like to introduce the technical aspect from our introduction on anesthesia improvement in technical quality and IT support in future, what you can expect. So let's dive into, as explained by Tabani, they are daily work statuses, too many devices and too much information all at once scattered throughout theatre. As you can see, the image shows the bispectral index, the neuromuscular transmission, all are scattered from the main screen. Either it's the vital screen or the anesthesia main screen. So how are we going to change this? We change this by using our registered trademark Anaesthetic solution. You'll see on the left-hand side of the screen. Anaesthetic is where we are connecting anesthesia machine patient monitor, and infusion dock. This can be done wired or wirelessly, and therefore it is ease of use for the medical professional. So you will have a complete display on the anesthesia screen and also remote control of all three devices. Not only that, is you will also have the secondary display of all devices connected on the patient monitor, which we will have a view on in detail later. On the right-hand side, you can see we have a data fusion. So this is an additional extra step from any site. So we've connected any site. We have our anesthesia machine, our patient monitor, and our infusion or induction devices connected. Additionally, on our N-series patient monitors, we have an optional inclusive feature known as iView. iView is literally a built-in Windows PC on your patient monitor. So what this does, it allows you to review patient history, patient data, patient diagnosis, as you would have done on a normal computer for medical records. Also, you'll see on the top on the screen, we have modular devices. So all N-series and EPM series patient monitors are customizable and interchangeable with a variety of modules. There's a maximum limit of 36 to choose from for the end user preference. Moving on, you can see details on the any site. So this slide has been presented by Tabani as from a clinical perspective. So from a technical perspective, you can see what any site also entails. As mentioned, it has a centralized control. It's got combined drug effect and the integrated assessment. On your right-hand side, that is a screenshot of the A9 anesthesia machine, and you'll see it says any site on the window, with the check marks for the infusion pump and network connected, showing your EMAC that is specific to Mindray and site equipment. This is calculated from our infusion or induction devices, the patient stats, and also patient information or demographics. This is another additional guide that helps the anesthetist or medical staff in diagnosing the current status of the patient. As previously mentioned, on our N-series patient monitor, this is what the end user will be looking at. So you'll see the monitor is divided into sections or departments. Top right-hand corner is your standard monitoring view. Your central layout in the screen is the anesthesia information, and you'll see on the left-hand side is the infusion view. This is all customizable to the end user preference. So each window can be maximized or minimized or viewed independently from a touchscreen point of view or a symbol, two-finger, multi-finger swipe left or right. Very convenient for the end user. In depth, if we're looking at iView, this is an example of iView. So in iView, you can incorporate your packs. Again, this is patient history for a single view, minimizing the clutter of multiple equipment in the OR. So as you can see, this one is specifically on packs for this patient. iView also then incorporates the HIS or the LIS or AIMS system. Again, this is customizable to the end user. So why are we doing this? We're doing this for the improvement of quality on anesthesia. Benefits of this, it saves the space in OR, decluttering the environment and having the medical staff focus on the vitals and on the patient. So this reduces human errors and reduces device and cable management. Also, the advantage this allows, again, all patient information to be displayed on one screen. As previously mentioned, either you can choose the anesthesia machine itself or the patient monitor, whichever is more preferred. And then again, time alignment. Why time alignment or synchronized time on all devices is crucial, is for the induction and for the status of the patient. Whenever there's an induction on infusion set, on a docking system, or the amount concentrated delivered from the vaporizers on an anesthesia machine, the time sync allows for accurate record keeping on the patient monitor for the reaction of these drugs induced. So our improved technology in the OR does not just stay in the OR. What we've included in our N-series monitor is the N1 transport module. This allows for a seamless transport from OR to recovery, or pre-operation can be from emergency, ICU, into OR. So what makes this difference is it gives a whole transport process for seamless monitoring and continuous monitoring. This is done by just transferring the module from a previous ward to the OR just by a push of the module into the satellite module rack. This N1 module has the option for Wi-Fi capability, meaning you will never lose communication with your central monitoring station or remote diagnosis, say if you have a medical professional in a different hospital or even a different country. So they have continuous monitoring. For example, if there was a loss in communication on Wi-Fi, the device does an auto backfill and will automatically log back all patient data or vitals once connection has been established. No end user interference is required. So let's look at the second level. So we've looked at the clinical application and the clinical need for improved technology in the OR. We looked at the technical background in how we do this, how we achieve the declutter and the improved environment for medical staff. So let's look at the second level. So we've already established Anaesthetic and remote control. So the second level is management across operating rooms. As previously mentioned, you can do a remote view on all devices connected on a central station or e-gateway system. And these are role managed access. So there is security incorporated into this. What this does is it gives a timely guidance and also gives a more timely manner of response on a specialist request. For example, if you have a student medical staff or junior anesthetist, they can always ring and have live data for a professional or experienced anesthetist or specialist on hand to see live data and guide them immediately. Secondly is the full department control. Not only can we just remote control and remote view our operating room or anesthesia machine, but also since you have connected all of these devices together, it gives you a full department control. Not only is this full department control accessible for medical staff, clinical staff, but also for the engineering and technical department. We'll go into detail why this is important. So for full department control, you can monitor remotely on a central station or on a web server. You can monitor not only one department in a hospital or a complete hospital, but you can do the entire hospital chain on one screen. So this gives remote guidance and then post-operative evaluation. This also gives device location and device management. So this is where our technical department comes in. How we do this? So we give selected and restricted access to only certain personnel by employing role IDs. So it can be an administrator, it can be a medical physician, or it can be a the receptionist or registered nurse. This access is, of course, from our central station directly. We have the workstation available. Also, you can do this remotely by our web viewer, and then you'll see on the bottom right-hand screen, there is remote access from mobile viewer. This is also all integrated with cybersecurity to incorporate the safety of patient data. We always recommend that you will use an intranet system, allowing a VPN if you are using mobile viewer or web viewer. On top of that, you can use a DMZ server to protect your mobile server. Looking at the role placements I've mentioned, so you have the medical director, or senior anesthetist, or junior anesthetist. These roles can then be assigned and they can view data according to the roles. So either it would be a workstation, a viewing station, or the full control, say for the senior anesthetist would be the CMS, full remote control. Again, there's an additional security layer on this remote control. Before accessing any remote control, a password is required and needs to be admitted or acknowledged on the physical device itself. So it's not a remote login without confirmation on the anesthesia machine, for example. Why we do remote control? Not only for secondary expert advice, this can be used for training on students, training, collaborating internationally, and also we have our DSA room solution, meaning the anesthetist or doctor can sit outside a radiation protected room and still administer anesthesia and have total control over the patient without having radiation harm to himself. Third level. So the third level is basically what we are focusing on as engineers, data-driven management and the improvement of quality for perioperative care. Our third level in our IT solution for OR improvement is, as you can see on screen, we have Mindray IoT dashboard or MIoT. What this dashboard allows is gas analysis for budgeting and then also for the regular consumption of anesthetic agent. This is divided per agent and can also then be filtered per machine or per device, per theater, and if you are connected your whole hospital chain, this can be divided per hospital, allowing you to analyze the usage of each equipment and are they being used at their maximum potential or are they being overused and should be budgeted for additional equipment. This is one advantage. The other is with gas analysis, this can be remotely printed and for budgeting purposes or billing purposes. Here's another example of the details. So the user friendliness of MIoT is that you can display and change your dashboard as you see fit. As an engineer, as accountant or procurement department can change this, or the medical professional can also change the layout as they see fit. How we get to this point for MIoT is we are using patient-centric data collection on all connected devices, and all these devices are then in a full disclosure. So all devices can then show either if it's vitals, alarms, reports, includes waveforms, and all of this can then in turn connect to any FHIR big data warehouse. In other words, any third-party hospital information system, EMR, LIS, PACS system. We make the integration seamless on these systems. Why we keep record of this is so that data analysis can be done, data collection, either for research purposes. Say you have a professor at a university that would like to do research. This is very beneficial for their end as well. As previously mentioned, for the engineering department, this allows for data management on devices strictly. Again, for budgeting and then also for remote access on alarms and also maintenance reminders. Our MConnect solution for the OR then covers three major points on IT improvement. So that is firstly, healthcare provider, medical devices, secondly, and then thirdly, information system. If our healthcare provider is improved in its devices, the patient safety has improved and efficiency on patient care has improved. Thank you for attending our short webinar. If you have any questions, you are free to ask myself or Tabane.
Thank you, gentlemen. Very informative. We have a few questions in the chat box. I think some of them may have already been answered. First question. Hi, Luke. Can the system integrate with different equipment or only Mindray? Luke?
Yes. So that's a good question. Thank you. I forgot to mention that actually. So our equipment does integrate with third-party devices, and we have a list of predetermined devices. Even if your device is not listed, we can always incorporate it. How we do this is we are using our N-series patient monitor, and we just include a Benelink device, and this connects to the third-party device, any brand, any model. They are using standard HL7 language, meaning that we can communicate with it. And so that is how we integrate third-party devices.
Okay, thank you, Luke. Next question from Deborah. Which pharmacokinetic models are on your syringe pumps?
We've got different ones, like almost all of them. And the updated one. So I believe that you're talking about whether the new one has been loaded or not. Because as I'm saying, then we do have like all the ones that are available on the market. So far, we do have them.
Okay. And then the last question from Ken is, so viewing could be done off-site, which I think was answered to a point. Luke?
Yes. So remote viewing can be done off-site as long as that end user has been registered and accepted by the main central station. And then also connectivity can either be done or responsible by the hospital or end user. And as mentioned, it is preferred to use a VPN for safety concerns.
Okay, perfect. All right, colleagues, there's no more questions on the chat box. Luke, and Tabani, if there are any questions, I think we can probably share via the Kiza platform, post this meeting if there's anything. But I think for now, there's no further questions. So thank you all for attending. And Tabani and Luke, thank you very much for your presentations.
Yeah, just to add on that, when it comes to the PK more models, I think it will take me a little bit longer to be able to explain, like as I'm saying, than the elaborate and whatever it is. So that's why I just covered it like that. If then maybe you need more of the information, I can be able to respond as well.
Okay.
Yeah.
Thank you very much for that. Colleagues, if there's no more questions. Okay, perfect. Thank you everybody for attending. Hope you all enjoyed today's session. Cheers.